Good morning, this is Eric Brzezinski presenting on Lara Taylor, a 35-year-old female G3P0A2, presenting today for her second routine prenatal visit at 20 weeks gestation. Her chief complaint today is of worsening constipation along with some new onset heartburn and intermittent low back pain. Laura reports constipation that began about 2 weeks ago. She says it comes on daily. It seems to be worsening in frequency and stool consistency. She describes it as hard stools and incomplete evacuation. There are no clear triggers, though she does note fluid and fiber intake. Nothing she's tried has helped, including fluids. She also reports some heartburn, especially after large meals, and some low back pain that worsens with standing and improves with rest. Laura's not taking any medications except for OTC prenatal vitamins, and she has an allergy to latex, which causes rash. PMH includes depression, and she was previously on Prozac but hasn't taken that in several years. Past surgical history, patient had an elective abortion at age 18 and a DNC 5 years ago. Her father died of a heart attack at age 60. Her mother is alive but has diabetes type 2. Patient is married and lives with her husband in an apartment. She's a third grade teacher working full time. She quit smoking when she became pregnant. She denies any alcohol or drug use. She does report being some concerned about her husband's unemployment and their finances, but she denies inter-partner violence. And she states that her husband smokes. Review of symptoms generally has weight gain of 8 pounds, but denies any fatigue or fever. GI reports some constipation, heartburn, no nausea, vomiting, diarrhea, no bleeding. For GU, she has some frequency, but no dysuria. Musculoskeletal, patient has some back pain, but no joint swelling or stiffening, no joint swelling or stiffness, and psychiatrically reports some anxiety about a pregnancy, but denies any suicidal ideation. All her systems reviewed and were negative. Objectively, patient's vitals are all within normal limits. 132/64 for BP, heart rate is 75, respir is 20, temp is 36.7, weight is 130 pounds, and BMI of 21.6. She appears generally well alert, well nourished, is somber initially, but she engages appropriately. Pertinent PE findings include a gravid abdomen, which is soft non-tender with a frontal height of 22 centimeters, consistent with 20-week gestation. Her cervix is closed. She has a normal bimanual exam and no CMT. Full range of motion, musculoskeletal with no joint swelling. Neuro, cardiovascular, respiratory, breast, and skin are all within normal limits. For labs, we got a CBC, a CMP, and UA, which were all normal. Her OB ultrasound shows normal fetal anatomy and growth, and her urine culture and GAD screening are pending. My primary diagnosis for this patient is of a normal intrauterine pregnancy at 20 weeks gestation, based on the fact that her frontal height matches gestational age, her stable vitals, and the fetal growth is appropriately. Describing this pathophys, pregnancy is caused by estrogen and progesterone, which are driving uterine growth, with the frontal height typically reaching the umbilicus around the 20-week point. Differentials include constipation of pregnancy, which is caused by progesterone, iron, and decreased activity, along with uterine pressure. Physiologic GERD of pregnancy, which is also caused by progesterone, which lowers the tone of the LES, and along with the enlarging uterus, increases intra-abdominal pressure. And finally, low back pain, mechanical low back pain from postural strain from the gravid uterus and ligament laxity. My plan includes medications like polyethylene glycol, 17 grams PO daily, Senna for emergency relief of constipation, Tums PRN, which can escalate to famotidine, 10 milligrams BID if needed, and acetaminophen as needed for her back pain. Non-pharmacologic management includes fiber of 20 to 30 grams a day, fluids in excess of 2 liters per day, and regular walking. I want her to take small, frequent meals, elevate the head of bed, and avoid GERD triggers as well. And I've given her some postural education, maternity support belt, and a core pelvic exercises to follow. We are awaiting the urine culture and the GAD screening for diagnostics, and we're planning to have a 1-hour glucose challenge in CBC at the 24-28 week mark. Education includes normal fetal development at 20 weeks and fetal movement expectations, constipation and GERD self-management strategies, medication safety in pregnancy, and reinforced body mechanics with safe pain relief options. Cultural considerations, I use a very plain language and a teach-back method. I offer dietary options that respect patient preferences, support emotional concerns with a trauma-informed approach. For health promotion, I want her to get her TDAP between 27 and 36 weeks. I encouraged moderate activity. We reviewed appropriate weight gain, 25 to 35 pounds total. Continued screening for depression and safety. I referred her to PT for persistent, or I can't refer her to PT for persistent back pain. And I did refer her to social work support if she desires help managing the stress or accessing resources. I want her to follow up here with the OB in 4 weeks or sooner if symptoms worsen. That concludes my presentation. Thank you.